Hello, good evening, welcome everyone, and thank you for joining us for tonight's education session on COVID adverse events following immunisation. My name is Charles Broadfoot and I'm one of the Professional Development Officers with Hunter New England Central Coast Primary Health Network. I would firstly like to acknowledge the First Peoples and traditional custodians of all the lands that which we are meeting on tonight and pay my respects to elders past, present and emerging. Tonight's session is being recorded and the recording and slides will become available from tomorrow morning in our PHN Education Library. So to access this recording and previous recordings, just head to our homepage, thepHN.com.au and click on the Education tab. There will be a short evaluation survey that will automatically pop up when the webinar ends. If you could just take a moment to fill this out before you log off, that would be great. We really appreciate any feedback that you can give us on our education sessions. You can type in questions of our presenters this evening in the questions box in your control panel. So please feel free to type questions throughout the presentations, but we have allocated time after these for a Q&A panel discussion. It's now my pleasure to introduce our facilitator for this evening, John Bailey. John is the Executive Manager for Primary Care Improvement with Hunter New England Central Coast, PHN, and he'll introduce tonight's speakers. So thanks again for joining us and I'll hand over to you, John.
Thanks, Charles, and welcome everyone. I'd also like to acknowledge the traditional owners of the lands on which we meet. This evening we've got some really good speakers and I'm sure you'll enjoy tonight's presentation. To discuss the matters of adverse events, we've got Professor Michael Boyle from the Clinical Immunology Department of John Hunter Hospital, Associate Professor Nicholas Wood, who's from the National Centre for Immunisation and Research Surveillance, Mr. Patrick Cashman, who is the Immunisation Coordinator for Hunter New England Health District and Population Health Unit, Dr. Joanne Wood, who's a GP at the Belmont COVID-19 Vaccine Centre. And as Charles has said, we will have some questions and answers at the end of the session, but please use the question panel as we go just to make things easier. And I'd now like to hand over to Nick for his presentation. Thanks, Nick.
Thanks, John. I'm hoping that you can all see my presentation. Is that working?
Yep, and if you just start, yep.
I'll just go there and go there. Oops, okay. So yeah, thanks very much, John, and hello everyone. It's great to be with you, and I'd also like to acknowledge the traditional owners of the land on which we're meeting today. This is such a hot topic and things are changing all the time, but I do feel very sorry, and it's hard for the GPs and the practice primary care to keep up with the changes. What I'd like to do in the short little while is just talk to you a little bit about the AEFI reporting that the ministry set up and the process. Talk a little bit about the AstraZeneca particularly, and then these topics here, stray into the TTS clotting story, ITP, and GBS, Guillain-Barré syndrome, and then a little bit on those last two topics over the next sort of 20 minutes or so. So just to reassure you that the as reporters of adverse events, they're not disregarded, they're taken seriously, and your local public health unit is one of the sort of stars in assessing and managing adverse events in the state. So it's fantastic to have people like Paddy and Jodie Stevenson and Dave Durham around to manage these reports in your region. And as you know, when the reports do get processed by public health and then they're passed on to the ministry, and there are lots of reports coming in, more than we've ever had, to be honest. These are then processed centrally by the Ministry of Health team and put onto a notifiable system. In addition, there's a surveillance system running in the background from the emergency department, which is also picking up cases. So there's quite a robust safety system in New South Wales to pick up these cases. I just wanted to touch base with you about the expert panels. And what happens is when we have serious cases, they are actually looked at by the ministry and on a daily basis triaged. If we have very serious adverse events such as deaths or ICU cases, we actually convene an expert panel, and Dave Durham is one of the co-chairs of those expert panels. This is the cases where there is a sort of either a death or an ICU case or an unusual case, or where there's family or clinician concern about the vaccine being causally linked. We started doing these ad hoc panels way back a few months ago, and it turned out that we were having to do them fairly regularly because there were lots of reports coming in. So now we've moved to a model where we have a weekly meeting with the haematology experts where we discuss the clotting cases, the ITP cases. We have every third week we meet with cardiology and neurology experts, and we discuss some of the unusual or severe reactions that might be reported. And then we're fortunate enough to have set up a fortnightly meeting with the allergy experts. And you're going to hear from Michael Boyle tonight, who comes to this meeting every fortnight. Fantastic contribution, one of the very sensible and logical. And again, you're very lucky in the Hunter region to have Michael around to manage these allergy cases. So I won't say much more on the allergy. We'll leave that to Michael to mention to you. NSWIS does have an email advice. We were a bit overwhelmed with phone calls, to be honest. We were finding that they were going through to the message bank. So we've now got an email set up, which we hope works fairly efficiently. We've got 2 or 3 medical fellows, a CNC and staff specialists trying to answer the emails on a daily basis. So I just want to quickly stray into this, the story about the AZ vaccine, and this leads us on to the TTS story. I think when people come in and say, should I get the AZ vaccine? I don't want to wait for the Pfizer, and they're young. This is happening more and more. I think it's important just to explain to them, obviously, the efficacy. I'll show you some information quickly about the risk of infection with Delta. That people do need 2 doses to be completely protected. Now then it strays into the safety, and I encourage you to have a look at AUSVAC safety website, which again has a fantastic contribution for the Hunter region with the Vax Tracker system, which Paddy is involved heavily in. We've got nearly over 2 million records now in this system, and Vax Tracker has contributed enormously to that. So I think it's quite useful to show people, if you have the time, the AUSVAC safety website, where there's a pictorial display of the safety profile in the first sort of 3 days after the vaccines. In terms of the TTS risk, I'll show you some graphs in a minute, but I think what's important is that people need to be told about the symptoms of the TTS and what they should do in the event that they experience these symptoms. In terms of infectivity, we now believe that the Delta variant is probably as infectious as chickenpox. The R0 is somewhere in the 4 to 5 range, and obviously more severe than chickenpox, but more so than the ancestral strain. In terms of effectiveness against the Delta strain, AstraZeneca at the top here, against hospitalisation and death, which is the key thing we want to prevent. You can see, that it's over 90% effective, as is the Pfizer after 2 doses. So people can be told that 2 doses is good. 1 dose, even 1 dose will give you some reasonable protection against hospitalisation and death, and it starts to work in that 2 to 3 weeks after that first dose. This is a snapshot of the people hospitalised between June and July, and you can see here that there were over 500 people hospitalised, and importantly, only 9 of those people were fully vaccinated, and from what I understand, a few of these people were frail elderly people who were admitted to hospital for sort of observation only, and none of these people that were fully vaccinated were actually in ICU or died. So in terms of outbreaks, there's a few points here, but the main one really is that there's attempts, if you can, to bring forward that second dose down of AstraZeneca down to 6 to 8 weeks. And in the younger age groups, we do have to have this risk-benefit discussion about the AstraZeneca side effects, in particular the clotting story. And the main issue really is that the clots are a little bit more common the younger you are compared to the older age group, but it's around about 2 to 3 per 100,000. The younger age groups, the risk estimates are not as robust. If we look at the confidence intervals around these rates, they do overlap a bit, but it is probably more, higher in the younger. And the other important part in the younger group is they tend to have the more unusual clots, which can be more severe. So the important thing to tell people is that if you do have any of these symptoms, which are in the centre of the box here, that they should seek medical advice. We know that the AstraZeneca in the first 24 to 48 hours can cause a headache and muscle aches and fever and chills, etc. If that goes away but then comes back beyond day 4, then the person needs to be probably looked at. If that headache is accompanied by other neurological things such as blurred vision, confusional seizures, then obviously that they must be looked at. So that's looking for the central venous sinus thrombosis, the clots in the head. The other place that clots have been found are in the abdomen, the splanchnic veins, that's the portal veins, and also in the pulmonary emboli, so in the lungs. So if people have these symptoms such as shortness of breath, chest pain, abdominal pain, they should also be looked at. And then there's a note there about unusual bruising, skin pinprick type bruising, and that's to look particularly for the thrombocytopenia story. I've written severe or persistent headache, but the people that we have had looked at in our adverse events expert panels, a few of them haven't really had a severe headache, and it's been a mild sort of headache, and one of them described it as like a hangover-style headache. And in fact, the person thought they had a hangover and ignored it, but ended up having a bit of a clot there. So it is important that people do get told about these things, because what we do know, there are algorithms, as shown on the left there, that the earlier we pick these up with the platelet count, the D-dimer, the quicker we can intervene with immunoglobulin, and the haematologists are getting very good recovery. So early detection leads to early management, leads to better outcomes. The other thing to say is that I mentioned ITP. TGA is monitoring cases of ITP after AstraZeneca, and there is a Scottish study suggesting that there is a small risk after the Oxford AstraZeneca vaccine. In red, there is a weekly link to the TGA, and every Thursday they update that safety report with the new cases that have been reported. So I encourage you to have a look at that one. The other thing that TGA is monitoring is GBS cases. The Europeans are also looking at it. So again, if you see a GBS or you become aware of a GBS, make sure it's reported, because it's only when we collect these cases around the country that we can build up to see if there's a signal. And the other thing is there have been some cases of capillary leak syndrome, but very, very rare. Okay. So the bottom line is, particularly when it comes to risk-benefit discussion around AstraZeneca or not in the younger, and there is obviously has been some hesitancy and anxiety about the clotting story, is that you can, show them the risk estimates, try and at least get 1 dose in of a vaccine. 1 dose will give you some protection. Ideally, think about bringing the second vaccine at a shorter interval, 6 to 8 weeks. I know that it's probably a little bit easier with AstraZeneca, more supply. And there has been some thoughts about spacing of the Pfizer vaccine to a routine interval of 6 weeks. But I'm not sure how much supply there is right now in your region, but yes, we know that there is supply coming. Just a couple of notes on mixed schedules, because it does lead into the next slide, which is the target advice on when to use them. Routinely not recommended to have a mix and match schedule, okay? There is some data showing that they might give better immune responses, but Australia has decided that we're not in that position to routinely recommend switching from one vaccine to another. Several European countries are giving Pfizer or Moderna as a second dose in those routinely if they've had AstraZeneca, but we're not in that position. So this came out just a couple of weeks ago, ATAGI advice on what to do with the second dose in special circumstances, and that mainly relates to adverse events. And these are the contraindication lists, which you all probably know. Michael will talk a little bit about the anaphylaxis story. I've explained a bit about the TTS. If they have that after first dose, then definitely not get AstraZeneca dose 2. Rarely capillary leak syndrome. And then this other catch-all phrase of any other serious adverse event attributed to the first dose. I'll say a little bit about the myocarditis, but I think if you have a definite ITP following dose 1 of any COVID vaccine, it can be reported after Pfizer, then it's probably worth discussing with your local haematologist about switching to a different brand. This any other serious adverse event is a tricky statement by ATAGI because there's definitional terms about what is meant by serious and what is meant by attributed. But I think if you've been hospitalised with the event and the subspecialist feels that it may have been related or potentially related, then it's worth having a think about whether we need to change to different vaccine. The other new thing was that if a person has had dose 1 but went okay, but has these particular issues, then they should move to Pfizer for dose 2. And the antiphospholipid syndrome has to be accompanied with thrombosis. Okay, so if they have any of these things, and even if they had dose 1, then the advice was to switch to dose 2. There is a form from New South Wales Health which you need to complete to think about a switch. And you can see here the main reasons, the ticker box of the conditions I mentioned before, and it includes that other serious adverse event in the second last tick box. And there is also information available which the PHM will have, as does the Public Health Unit, on how the process for requesting an alternative vaccine. We'll make these slides available for you so you can have a look at them after tonight's talk, because we've moved pretty quickly. ATAGI guidance has some nice flowcharts, which they are actually amending slightly, but not too significantly, and they're fairly easy to follow. And Michael will talk to you a bit about the anaphylaxis story, and whether or not individual assessment may mean that they don't need to be switched. But we can let Michael talk to you about the allergy story as well as other things. Now, if they do switch from an AZ to a Pfizer combination, what we do know is that they're possibly, this is based actually just on one study, but there is some real world data coming out from our experience with Osvac safety soon. But if you do have a Pfizer dose 2 after an AZ dose 1, you might be a little bit more likely to get some injection site pain, myalgia, malaise, headache, etc. So the person, if they do switch, just needs to be aware of that potential increase in side effects. And the last little bit I just wanted to talk to you about was another signal, which is the myocarditis story. Has been found after the mRNA vaccines, so both Pfizer and Moderna, usually in younger males, and often after the second dose. Now, people are being assessed with ECGs, chest x-rays, troponin, and possibly things like cardiac MRIs. Well, we also know that the cases that have been definitive cases of myocarditis or pericarditis can be treated with non-steroidals, and some people are getting colchicine and have been in pretty good resolution. There is a guidance like this that will come out. This is from the Toronto Sick Kids one, which will be developed an Australian equivalent. This will be quite useful when we move down into the pediatric space to give these, because there may well be some cases we see in the pediatric space. Again, ATAGI has some guidance out on the for myocarditis and pericarditis. I won't go through that in detail, but important points just to bring to you were, if people have these particular 6 dot points here below the red lines, that they just need to think about the best timing. It might mean that for example, that if you're going to have an ablation of your heart or something, of the actual, say, for example, a conduct, an issue from arrhythmia, because you've got complex heart disease, you might just think about what the best timing for the vaccine is. They are going to slightly change the ruling about the myocarditis, pericarditis note there, to say that it's probably more likely if you've had myocarditis or pericarditis in the last 6 months. That's our more definite concern. And then if you do have an episode of myocarditis or pericarditis, and where other causes have been excluded, then the advice is to think about not getting another dose of the mRNA vaccine and discuss that with their treating doctor. An important point for clinicians out there is that if we can do our best to label the person with true myocarditis or true pericarditis based on the objective things like the ECG or the troponins or the inflammatory markers. What we're finding in the ED system is that when we look at cases of these things that have been reported, people are being told that they may have some mild pericarditis and it may have been related to the vaccine, but there's no hard definitive evidence of that. And the problem then is that the person walks out of the ED, all they hear is, yes, you had pericarditis from the vaccine, and it becomes an issue about what we do for dose 2. So we're working with the ministry to try and put out some information about that, but it has certainly resulted in a fair few cases of not only people presenting to GPs and emergency departments, but the emergency department labelling these as pericarditis when they may not really be a true pericarditis. And perhaps what that person might have called a costochondritis or an atypical chest pain, 6 or 9 months ago. So just a plug on that one. Again, the TAGI has some guidance about what to do for reaction to community. I won't go into detail with that one. So if you do have that, and it's a true case, they should be admitted, be monitored, and wait till they have recovered before discharged, or at least the symptoms have resolved. There's a note here that if they have a true myocarditis, that they should avoid exercise or competitive sports until their ECG has resolved and it's all normalised, and check with the vaccine specialist or particularly the medical cardiologist about the vaccine switch. There was some information going around about any young person having Pfizer should avoid high intensity exercise. That's not a necessary requirement. It's just if you've had the myocarditis confirmed, then you need to avoid high intensity exercise. And the last thing from me is that we are moving down the ages. ATAGI has recommended these 3 groups for Pfizer. There will be more information coming on particularly the Appendix A kids and how to manage this, but in parts of the country, we do want to vaccinate our Aboriginal and Torres Strait Islander children to protect them as well. So that take-home messages from me really are that if we can at least get 1 dose in, that will give people some pretty good protection. I saw a slide the other day, or today actually, showing that we are doing pretty well with, over, 70% plus of the over 60s having had at least 1 dose. So we're getting there. Encourage you to make sure that you do report things through the public health channels, because each report is, particularly the most important ones to report are the adverse events of special interest, the serious ones. Just the routine, malaise, aches and pains, etc. we don't need to report, but the serious ones do, and there is a process for them to be triaged and taken seriously and fed back to you if as much as we can, and local. The Hunter unit, public health unit, does that really well. So that's it from me, and I'll hand over to Michael to go next. If I can work out how to stop sharing.
Unfortunately, Michael's webcam's not working, so we only have audio from Michael tonight.
Yeah, sorry about I'm sort of the Dark Lord here. I haven't got a webcam that works. I have a feeling I've been net-nattied out. But anyhow, so COVID vaccines, I'm assuming you can see my screen. I thought I'd just start with a simple bit. You know, we've had a lot of cases globally. We've had a lot of death, 2.1%. But we've also had a vast amount of vaccine given. So we collectively have pretty good data on the benefits, pros and cons and risks. Common side effects are really quite well defined. And when people try and say, you know, oh, we don't know enough about it, it's been rushed, really, we have a lot of data and information, and it's been running for a year. So I think we just need to break down that sort of resistance a bit. We do have a pretty good idea. We started with clinical trials that said they worked. They started with a Pfizer trial that had about 40,000 in it. They then said there were 162 placebo-infected, 8 cases, so they called that 95% effective. If you think about that, that's not overwhelmingly convincing, but it's good. The AZ trial had much more of a hodgepodge of data. They only had 11,000 people, and they came out with a 70% efficacy using the same kind of metric. But if you look at the confidence intervals of all of these trials, they overlapped. So there's no statistical difference between them. And the trials in different countries with different subtypes and protocols made that very difficult to really know. And as you can imagine, with those numbers, we would never have realized that there was a clot issue, and rare immune issues were not really detectable. There's then the big trials that started, which were real life trials, saying, we just look at how many people get admitted, how many people die. And this is the sort of Scottish and English data. They're probably the most useful to us because they have both Pfizer and AstraZeneca available. And in the Scottish cohort of 5.4 million people, of which 35 were vaccinated, 35%, the effectiveness of the two vaccine was basically comparable. In terms of the things that matter, death and hospitalisation. The issue that's come up more recently is breakthrough infection, where a small percentage of vaccinated people develop symptomatic or asymptomatic infection. So currently, when the US looked at a group of 10,000 who they found it, among 101 million, 27% were asymptomatic, 73% had low-level symptoms, 10% of them ended up being hospitalised, and 2% died. And the mean age of the mortality was 82. And just to contradict Nicholas slightly, we have had one death from COVID in Hunter, but that was someone who was on a palliative pathway in their 90s, in whom they didn't go to intensive care because there would have been no point. They'd already been designated not for resuscitation prior to developing COVID, and therefore no action was taken when they became more unwell, as we wouldn't know whether that was due to COVID or not. There is concern about breakthrough rates in immunocompromise, and that's why you've seen the US recently think about giving booster doses to people who are immunocompromised or transplanted. The other thing to remember when we get the anti-vax lobby at us is that currently most of the mortality is in the unvaccinated, but as the vaccinated become 90% of the population and fewer people die of COVID, then the percentage of people who are dying will be much smaller, but they'll still exist, and the percentage of that group who will be vaccinated will become higher. That's not a sign of failure of vaccination, that's just a sign that it works, but it's never going to be 100%, which is true of all the vaccines. So let's get on to where we should be, allergy side effects, which is why I'm here. So the common side effects of any vaccine are things like fevers, chills, myalgia, tiredness, headache, arthralgia, some local pain, adenopathy a few days later. We've had a bunch of people complain about that. Whereas I would say that tells me my immune stimulation is working. It's doing what it's supposed to do. Side effects may be more or less common after the second shot. Some people find it is, some find it isn't. And the intensity of reaction and the perception of that intensity varies across the population, and I'm sure you're all aware of that. Most of this can be managed with simple antihistamines, simple analgesia. Most of it occurs in the first 1 to 7 days, and none of this should preclude a second dose. Anaphylaxis, when the Americans have really looked hard at this, comes down to about 4.5 per million, based on their first 10 million doses. The rates are similar for AstraZeneca and Pfizer, and they're similar to in all of the vaccines we use, including flu, tetanus, and so on. So anaphylaxis occurs in about 15 minutes in 80%. And by 30 minutes, you've got 90% plus. There's a lot of concern about anaphylaxis, but it is in fact rare. Often when they go to emergency with a possible anaphylaxis hours after the event, I would really plead that people do tryptase levels, because it helps us when we go to look at what happened. Was this anaphylaxis or was it not? Thinking about the likelihood of us needing to do revaccination down the line, it is really helpful to know upfront if someone presents to an ED with a possible anaphylaxis, whether it really is or really isn't. So things that help are doing tryptase levels, making sure we document what their blood pressure is during the event. Were they hypertensive or were they hypertensive? When they were having breathlessness, did they develop O2 desaturation? Did they have a gas done? Did they have even just oximetry done? Because patients report allergic symptoms and panic attacks and consequences of that far more commonly than they do anaphylaxis. They just switch the words around. They think of it as anaphylaxis, but a lot of it is not. And certainly, if you talk to Joe, who comes after me in the talking, you'll find that that's been a really common issue through Hunter as we roll things out. So if you look at a study in Massachusetts, they studied staff vaccination because we're a bit of a captive audience, and they did a lot of surveying. 60,000 were vaccinated, 50,000 completed the survey, and self-report of allergy was about 2.5% of the vaccine recipients. 99% got reassured, were reassured it would be okay, and they went back and had their second dose, and not a lot happened. But 0.7% didn't go back. 860 reported after the second dose having minor symptoms only. So the reassurance is actually very effective for the majority of people. And we need to be mindful of that if we actually want to get the vaccine rollout to work and include 90% of the population and not have a whole lot drop out. A second study was conducted in Boston, where they studied 190 people who reported allergic symptoms that they would have reported as anaphylaxis. So you had to have more than one feature that would fit in an anaphylaxis almanac, and you had to have onset under 4 hours. But as I just told you, virtually all of the anaphylaxis starts within half an hour to 45 minutes. You don't have anaphylaxis hours later. And all received an RNA vaccine. 28% had flushing and erythema. 26% had dizziness and lightheadedness. Throat tightness here has been a big issue, and throat tightness is not uncommon in the group. 21% had some wheeze and shortness of breath, and 21% had hives of urticaria. 159 agreed to a second shot and safely did it. 32 of them, or 20%, reported repeat symptoms, which were managed with antihistamines alone. In our region, I'd have to say we've had people giving up to 5 doses of adrenaline for this kind of presentation, with flushing, a throat tightness, normal oximetry, and no hives, and hypertension. So included, they had 19 who the patients were very convinced they had anaphylaxis, and their practitioners would have classed them as hard to classify as either anaphylaxis or not. It highlights to me our problem with working out what it is that we're dealing with when someone says, I had anaphylaxis. So the diagnosis of anaphylaxis has criteria. So the way immunologists think about it is it's highly likely to have one of the three things. You've got to have skin, mucosal, or both, so hives, pruritus, flushing, swollen lips, swollen tongue. Usually they come together. And at least one of the following: respiratory compromise, which usually involves substantial respiratory distress, but particularly also, if you look at them carefully, if you do gases, you can find they're hyperventilating, but they're not improving their oxygen. If you reduce the blood pressure, that's really helpful. But sometimes the big DDs for both of these things, we're going to discuss in a minute. The other way you can have it is you might avoid the skin involvement, but you can have that. But you can have no skin involvement if you have very severe hypotension, because it's hard to mount a skin rash if there's no blood supply. Diarrhea and abdominal cramping are features. And in infants and children, you set different characteristics about blood pressure fall. But in the clinics that we've been manning and looking at, vasovagal reactions have been really very common, particularly with all of the hype in the community about how bad the vaccines are in terms of side effects. So vasovagal reactions are characterized by hypotension, pallor rather than erythema, diaphoresis, weakness, nausea, vomiting, bradycardia. If it's severe, some people will lose consciousness. They can have cutaneous signs of pallor and sweating and flushing, but typically not itching, not urticaria, not angioedema. There's another condition that people are less familiar with, which does involve a degree of hyperventilation, but they will complain of stridor or difficulty talking. They'll complain of intense throat fullness and dryness, and they'll feel breathless, like it's very hard to breathe. Their oxygen saturation is typically normal, and they're typically hypertensive, not hypotensive, because they're incredibly anxious. They're usually very distressed, hyperventilating, and they can become confused and start getting muscle jerks from myoclonus simply because of the degree to which they are hyperventilating and elevating their lactate due to muscle spasm. And we've had a few of those, and usually they get given a large volume of adrenaline, but the basics of determining what exactly they have, meaning measuring their blood pressure, measuring what's going on, isn't well done, and rarely is a tryptase performed. And those things are really helpful when you're trying to work it out. You're sitting on committees trying to say, is this an anaphylaxis or is it not? What about other allergic reactions? Delayed urticaria, more than 2 hours after the first dose, is not a contraindication to the repeat dose. You basically use antihistamines rather than steroids. Often it's a one-off and they don't get it again, but because they're often quite anxious about it, you would need to dose them prior to their second dose and do it for a number of days just to make sure they don't get it, because it makes it very distressing for them. And remember, if we want to give them follow-up doses later, we've got to make this as comfortable as possible. Delayed local reactions looking like cellulitis, you'd manage with topical steroid. You just give the second dose in the other arm. You can give antihistamines if needed, but usually it's not recurrent. You can, with a history of flu vaccination problems, it's typically not a contraindication to vaccine, because all of the same problems we have with panic attacks and hyperventilation and fainting in association with COVID vaccination occurs with flu vaccination. As someone who's been doing the flu vaccine for the really people who claim they've had anaphylaxis and people are worried about it and send them into the clinic, we've done that for some years now, and I've yet to see a flu vax anaphylaxis. It's not common, but statements of flu vaccine related anaphylaxis is really quite common. It used to be blamed on egg allergy, But egg allergy is really only relevant to yellow fever vaccine, has not ever been relevant to flu vax, and it's not relevant to COVID vaccination. The flu vaccine contains some polysorbate in some iterations of the flu vax, though it didn't used to at all times. And COVID vaccination depends on whether you're AstraZeneca, where you've got the polysorbate, or Pfizer, where you've got the PEG. So skin testing to vaccines, we rarely use because you get false positives, which will mean we take them out of long-term vaccination, whichever agent I've used. So if I do testing to Pfizer, it would need to have a good cause. Because if I do that and it says they have a positive skin test, then you've kind of gone back to now we can't give them another dose unless we take the risk. You need to know whether you've got a convincing story for anaphylaxis before you do that, because you'd make it very difficult. For vocal cord dysfunction and anxiety, if that's really the diagnosis, then generally verbal reassurance, distraction during the injection, so they've got other things to think about. Sipping water helps, because if they're sipping water, it's hard to get your vocal cords not to abduct and be comfortable. And observation is usually very effective. You give them half an hour, 3/4 of an hour in the same place being chatted to, and they usually get much better. And most of the people we've had who've had significant vocal cord dysfunction and anxiety in their first episode get through the second vaccine very easily. Now, what about the more severe delayed reactions? So serum sickness to vaccination can occur, but is rare. Then you tend to present later with fevers, arthralgia not in those first few days, and you get rash. The diagnosis is clinical. There's really no good test, and a tryptase won't tell you anything other than be normal. A blood count may show some neutropenia or eosinophil elevation and complement changes, but often that's not conclusive, and skin tests are really not useful. It's not an IgE reaction. Severe dermal reactions, which there are case reports and short case series that you can look up, one's in the New England Journal. Things like toxic epidermal necrolysis, Stevens-Johnson are rare, but I think the case series I saw was about 20 of quite significant dermal reactions. And for that, you would choose another vaccine. You wouldn't repeat that. So we have referred people for a change in vaccine where we've seen 1 or 2 of those. So I might stop there and hand over to Jo for her experience from the hub.
Now, I think I'm failing my web share, my screen sharing.
So Jo, we can see your desktop at the moment. Yep.
Can you see screen two?
Yep. I think we're seeing your opposite screen. So you might need to drag your PowerPoint across. Yep.
Go.
And
there we go. Can you see it?
yeah, and just change your display settings around so we're just seeing your presenter view. So up the top, yeah, on the top left in the middle, you'll see the words display settings.
Yep. Yep.
Yep. Mm-hmm. And then just, yep, and then swap.
That's it.
Very good.
I passed. Well done. Thanks, Charles. All right. I'm actually sort of going to go through a few basics. So Nicholas alluded to the referral pathway to get people that are over 60 into the the Newcastle Vaccination Hub who have indications for an alternative vaccination. So I'm going to go through quickly where you can find that stuff on health pathways, and then I'll touch on the experiences that we're having seeing people after vaccinations at the hub as well that Michael was also discussing then. So I'm hoping that most people are familiar. So this is relevant for the Hunter New England footprint. People that are referring in that area, so GPs in there. I'm sure everyone's hopefully familiar with the username and password now for health pathways. We have a collection of COVID-19 pages. The one that's getting the most hits at the moment is the COVID-19 vaccination collection. In that, we have some vaccination information. So a lot of the content that we've covered today is housed in there. A procedure pathway, a helpful clinical pathway for trying to tease out the diagnostic criteria around TTS, and sort of working out those tricky clinical scenarios that we see in general practice, where trying to work out whether it's appropriate to investigate in that setting or sending off to ED straight away. And then the one that I'm going to talk to you about today is the COVID-19 vaccination referrals and advice section. In that section, we have a little bit on seeking advice. So that's the resources that we would have, like Nicholas sort of hosts there. And then the referrals bit is how we locally can get people in to get a Pfizer vaccination if they are eligible in that over 60 bracket. There's some basic information. I'm sure everyone's familiar now that if you have people asking about where they can get a vaccine, they can go through the vaccine eligibility checker and work out if they're eligible or not. And then it'll point them in the direction of the various clinics around that are able to vaccinate. If you have someone that's over 60 or someone who has had a reaction to a Pfizer vaccine, we haven't had one of those come through yet, this will also be relevant for them, then they can be referred to a Hunter New England LHD vaccination hub. We have some local requirements around that as well. So there is that form that Nicholas pointed out, which is useful to a degree, but sometimes we need a little bit of extra information to really be able to just work out if we can just push the referral through nice and quickly, or if we need to get extra advice from Michael, or depending on what that. It's usually the other adverse reaction that people have had that is trickier to work out, and that we sometimes need to escalate for some extra advice. But it's GPs that are working in the hub mostly. We have an ED doctor as well, and a CMO with us. But so we're working off the same criteria that all of us in GP land that are vaccinating are, and I think probably people are very familiar now with the indications. If you do the form, that's great, but if you can give us some extra information, that's really, really helpful as well. So we do say a referral with information would be helpful as well in our local pathway. These are sort of just I put these in because I wasn't quite sure if the others would cover them, but I think we've covered these adverse reactions and that we see with AstraZeneca and with Pfizer. But this is a particular resource that I wanted to draw everyone's attention to, that the Victorian Health Department have put out created by their emergency departments, I think, and it's a very helpful document that sort of separates out acute stress response from an anaphylactic response. So we learnt very quickly at the when we had the hub at the John Hunter that the subjective experience of an anaphylaxis and the descriptions that people give are very hard to tease out from an acute stress response. So getting some extra evidence of actual cardiovascular or respiratory compromise is really, really important in being able to reassure the patient and just sit on it for a little bit and just wait for things to settle down. So there's this big sort of spectrum that we're seeing that Michael has really sort of discussed already, where someone will have a heightened response straight after their vaccination and start to feel pretty awful, and they can describe things like a tightness in their throat or in their chest, sometimes a bit of tingling in their fingers or their toes. They might even get a bit flushed, and we'll bring them in and be nice and reassuring, and we have a medical space that we're seeing them in separately to where the vaccination is mostly happening. Do a set of OBS and discover that they're hypertensive, their SATs are completely fine, they sometimes might be a little bit tachycardic even, and then after a period, very, very brief period, they have a glass of water and sip and a chat and are distracted, or they may have some underlying anxiety and they engage their techniques or tools that they have for managing anxiety and settle very rapidly. Some people have a vagal response in that setting as well, and they have a corresponding sort of drop in their blood pressure, of course, and their heart rate goes right down to their boots, and they look very pale and respond very rapidly to a quick lie down on the floor with their feet in the air. And again, that's all, when you put it all together, it's relatively easy to sort of separate out from anaphylaxis. But we have had a few referrals through to the hub of people, which, you know, now with the benefit of hindsight and thinking about it, like it's quite possible that they've had that acute stress response, and because of the reported symptoms, and, you know, we're all on red alert for anaphylaxis and appropriately should be treating it if we think it's happening. But you know, just wonder if maybe that's what had happened in that situation. So if you can, and you do have access to being able to get a set of OBS, it does help. But, you know, all of this messaging is, you know, to be cautious, and if you're worried, of course, proceed to treating an anaphylaxis. But that's certainly been our experience. We've had that little bit of a luxury of seeing it a lot of times and having, you know, a nice setting to be able to just quickly do a set of OBS, be reassuring, watch it all sort of settle down pretty much instantly before your eyes, and then they can proceed to their second vaccination without having to worry about missing out. So that is actually the main point of my presentation, and I'm hoping that we have some extra questions as we go through. Thanks, guys.
Thanks, Jo. Thank you, Michael. Thanks, Nick. We do have some questions. So what I'm going to do now is go through the questions, and hopefully one of the panel will jump in and rescue me and answer them. So the first question that we have is from Dr. Daikut in Bingra, and that is, what's the minimum age for Pfizer? Anyone?
Well, at the moment it's 18, but it's moving down to 12. That's what Nick told us.
Yeah, in certain circumstances.
Yes.
Yeah. Thank you. Do we have a death rate from TTS for each of the age groups? And if we do, can we share the source, and we'll put it with the Q&A tomorrow?
Yeah, I believe there's quite a few resources out there, John. So, and that COVID information page on Health Pathways has some good resources. And I'm thinking if you're using it for sort of helping to inform patient decision making, there's a section in that COVID information page that has some beautiful side-by-side graphics as well to try sort of help patients sort of see the difference between the vaccination death rates, which are very tiny, compared to you know, higher outbreak settings and COVID death rates and the lower settings as well. Hopefully that's
right.
what they're after.
Yep, thanks. Before we do any more questions, we might hand over to Patrick.
Thanks, John. Can you see my slides?
Yes, thank you.
Yep, great. Hello, everyone. Thank you very much to Nick and Michael and Jo. I'll just present a few other things, and then most of the rest of the time we'll have for questions. Just a reminder that you're all working very hard to give out COVID vaccines, and that's incredibly worthwhile, even with this Delta variant. So this is a new paper that came out last week in the New England Journal. Because we're Hunter New England Health and cover the New England part of New South Wales, I like to think of this as our own journal, top quality coming out of our own backyard. And this is showing that against the Delta variant, both vaccines work really well. The main graph here shows that the Pfizer vaccine here on the left and the AstraZeneca, this is for one dose, but you can see it jumps up enormously for two. On the right-hand side, that's shown a bit more clearly. So this is either vaccine. So for one dose, you're getting under 50% protection, but that really jumps up for dose two. So catching people up for that second dose is really, really important in terms of disease prevention. And that's why the recommendation to bring down that interval for AstraZeneca from 3 months down to 6 weeks, and even down to four weeks if needed. So the second dose is really, really important. So chasing people up, all the recall systems, reminding people to come back for that second dose is going to make a huge difference in terms of their protection. Nick talked about this, and we've talked a lot about today about at the moment we have limited vaccines. So the advice is for people under 60 to consider having an AstraZeneca vaccine, and a lot of people will be nervous, but there's really good advice now about if you can have your second AstraZeneca vaccine, even if you've had the sort of thing that Joe and Michael have nicely described, where you felt a bit unwell at the time of vaccination, that's not a contraindication to having your second AstraZeneca vaccine. And you're not by giving someone a second AstraZeneca vaccine, it's really not a second-rate vaccine, and we've really got to be confident in giving it, especially to people over 60, because the risks of blood clots in that group are low, the risks of the disease are high. The epidemiological data at the moment really shows that the disease is getting transmitted around New South Wales by young adults. The average age of the people with COVID in the Hunter, New England area is about 26, and that's even including some of those nursing home residents that have got sick recently. So it's young adults are taking the disease around. So we really want Pfizer preserved for people under 60, and as much as possible be giving the AstraZeneca to people over 60. And you know that the second dose, the rates of adverse events with AstraZeneca are much less. And if they haven't had TTS with the first dose, the chances of them having that with the second dose are incredibly low. So you can give that second dose confidently. And in the future, we expect all the boosting doses to be given with Pfizer anyway. Now, why would that be the case? So just a reminder, this is just a graphic of the Oxford AstraZeneca vaccine, and it's a non-replicating viral vaccine. So this is the adenovirus. An adenovirus is a common respiratory virus. So the DNA from the spike protein, to make the spike protein, is put inside a nice hard case of an adenovirus, and then the adenovirus gets into our cells, the DNA gets into the nucleus, and then the spike proteins, or the harmless spike proteins, are produced, expressed on the outside of the cell, and then our immune system picks them up. But the bit I want to draw your attention to is this bit here. So we used to be called the ChAdOx vaccine. So the OX is for Oxford University, and there's much excitement about this because Oxford University said, no, we don't want to make any money out of this. That's why it's being used around the world in so many places. And the CH is the chimpanzee. So the adenovirus is a chimpanzee adenovirus, because if we used a human adenovirus, your immune system would have seen that plenty of times, and it would disable that as soon as it saw it. So we use a chimpanzee adenovirus, which your body's never seen. Your immune system doesn't know, so that can work really, really well. But if you had repeated doses of the AstraZeneca vaccine, your immune system would start to recognize the chimpanzee adenovirus. So we don't think this is the vaccine for repeated doses. So if you give 2 doses of AstraZeneca to someone now, likely is that they're going to have Pfizer boosters in the future. So you're not doing anyone any disservice by giving that second AstraZeneca vaccine. The Pfizer vaccine, just a reminder that you're only giving a little piece of the RNA. So it's a very, very delicate, which is why we've got to treat it delicately, and why it was the Pfizer was initially frozen at -70. So it's very, very fragile. Now, today we're talking about adverse events, but just a reminder now, a lot of people are drawing up these vaccines and giving them, but you need to be really gentle with it, because that RNA is incredibly delicate, and it's just in this little fatty casing, and then it's injected straight in, and then the RNA actually, it's the messenger RNA, so it has the recipe for creating the viral protein, so it doesn't go into the nucleus at all. But if you're not careful, so a lot of people are giving a lot of vaccines, we're getting fatigued. It looks like there's more vaccines on the way in the next few months, the Commonwealth government are telling us. So we're going to be giving a lot more vaccines in the next few months, and we want to vaccinate as much of the population this calendar year as possible. But that doesn't mean we decrease the quality of what we're doing. So if you're going to shake that vaccine around, if you're not paying attention, if you're diluting it with the wrong amount of normal saline, it's not going to work properly. So although everyone's exhausted, we're going to be working a lot more, vaccinating a lot more people, but the quality of what we're doing is really, really important, because if we're not doing it properly, the vaccine's not going to work properly if that RNA is shaken around. You really don't have to worry too much about those immediate adverse events like Michael and Joe have been saying. And the interesting thing is, a lot of those things with good medical care and good bedside manner and looking after people and making them confident and spending some time with them, you can talk down or manage a lot of those at in your clinic really, really well. Now, that is really difficult when you've got a queue of 100 people outside your general practice all wanting a vaccine. It's a high volume thing that you're doing, but still taking that time to just talk people through what's going on. So those immediate effects that you see when someone gets any sort of needle, you can really manage really well in the clinic. But that's really hard when you're trying to get high volume, you've got a lot of pressure to get people through, but taking that extra minute or two with someone to talk to them can really make their experience a whole lot different, and then they'll be much happier to come back for the second dose. Now, just a reminder, so on the left is the what's inside the, or what's in the Pfizer vaccine. Now, the first one is, of course, the RNA, which is the active ingredient. Now, the next four are the lipid casing. So that's what's around the lipid casing. And Michael talked about this second one here, polyethylene glycol, or PEG, which can very occasionally cause anaphylaxis. But like Michael said, that's really rare. So you've got these four things are the lipid casing. The next four are salts, and then you've got sugar and water. So there's nothing really in the vaccine that's going to cause someone to have a terrible episode straight away there in your clinic. There is stuff in the vaccine to cause a good immune response, and then the next day they may be feeling very poorly and may need a day off work before they bounce back, but there's nothing in there that's going to cause an immediate reaction, except for the very, very rare cases of anaphylaxis. And as Michael said, that's very rare. And it's a similar case with the AstraZeneca. There's the active ingredient, which is the adenovirus vector. Then you've just got some amino acids, salts, sugar, alcohol, and the surfactant, the polysorbate 80, that stops the vaccine getting absorbed into the glass vial. And polysorbate 80 is a very common ingredient in many of the foods we have in soft serve ice cream and things like that. So that's not an unknown thing. So there's really nothing in these vaccines that are going to cause immediate problems. So when you're giving the vaccine and someone's struggling immediately afterwards, that's probably the pain of the needle and the whole experience rather than what's in the vaccine causing that problem. So you can have confidence to talk them through it. And like Michael says, you don't have to reach for the adrenaline as your first port of call. So we do have a whole system of safety that Nick's described really well. So I designed the Vax Tracker system, and we've had over nearly 2 million people through that now. It's been used all around Australia. A wonderful GP in Perth, Dr. Alan Lieb, designed the SmartVax system, which some of you in GP practices may be using. And we're sending SMSs or emails on day 3 and 8, and then 6 weeks after the second dose. And we're getting a lot of really good information. Now, this is over 1 million responses to the Pfizer vaccine dose 1 here on the left, and you can see that 62% of people who had that vaccine reported they had no events at all. And down here on the bottom left, only 0.5% of people sought medical attention afterwards. Whereas you compare that to the second dose, only 43% of people reported having no adverse event, and 1.3% of people sought having medical advice. So with the Comirnaty vaccine, the second dose causes people to be knocked around a little bit more the day following the vaccine rather than the first dose. Whereas if you look at AstraZeneca, the Ausvax safety data on that is the opposite. So we've got a low adverse event rate with the first dose and higher with the first dose and lower with the second dose. So it's the opposite. So when you're giving the vaccines, you can give people a good idea of what to expect when, and that Ausvax safety is public, data is all publicly available there. And the things that we're talking about in terms of adverse events are the common adverse events here a few days after the vaccine. So it's fatigue, headache, body aches, and things like that, and injection site reaction, of course. And again, even though you might be giving 100 a day, making sure you've got good injection technique is going to make a huge difference. So we do want very serious adverse events reported directly to the public health unit on the usual form. We've also got many other ways of finding out about these. For minor adverse events, you can report them directly to the TGA, or the person involved can report them to the TGA. The TGA, this is data from the 8th of August. They've had over 48,000 adverse events reported. So there's a lot of surveillance of adverse events. So people are worried that no one's having a look. We're looking very, very carefully. The TGA reported last week, so this is up to the 12th of August. In the last week, there was a 22-year-old woman from Victoria with TTS and an 82-year-old man from Western Australia, and 9 new probable cases that are being investigated. So there's a whole system of vaccine safety of which Nick's leading in Australia and Michael's a huge part of. So there's a lot of scrutiny of what's happening. And again, this is very recent data from last week. So overall in Australia, there's been 104 cases of TTS, and I think one of the questions were how many fatal cases, and this is again from the TGA website, and there's been 6 fatal cases of TTS in Australia, and they are really more, a lot of them were when we were first getting used to this syndrome and didn't know a lot about it, but now with early diagnosis and pick up, they're much more treatable and people are getting treated earlier. So the death rate's falling from TTS in Australia. So this is a slide from Anup Anjeti, who did a wonderful talk in this forum a few weeks ago. If someone progresses to scanning, that this is the CVST that we're trying to avoid with early diagnosis. And just a reminder that the pathway for the clotting that we're talking about is completely different to the normal clotting that you treating people for. So you've got patients who may be a bit overweight, a bit sedentary, maybe they still smoke cigarettes, and they're in line for a stroke later in life. And so you're managing them to prevent a stroke. So there's a lot of people over 60 who have lots of conversations with their GPs and practice staff about preventing blood clots. But the mechanism for blood clots from the AstraZeneca is completely different. And this is a slide off the net from Core-IM. And this is about the heparin-induced thrombocytopenia, but we think the mechanism is similar for the VIT, and it's the antibodies here, the little blue Y-shaped things that cause the platelets to stick together. So the mechanism's completely different. So if people are worried about, they're over 60, they're worried about having the AstraZeneca, and they may be a sitting duck for conventional clots, that doesn't mean they're going to have an AstraZeneca clot. So the mechanism's completely different. So the guidelines that Nick and Michael and Joe have outlined about that normal, so they've had DVTs before, they've had strokes before, they can still have the AstraZeneca vaccine if they're over 60. But be mindful of people who've had AstraZeneca. There's wonderful advice from THANS, of which Anup Anjeti, our local hematologist, is leading in Australia. There's wonderful flow charts. This one's for GPs, so this is worth having by your side. And if you are worried about a clot, then you need to be sending off urgent hematology, especially D-dimer and platelets, and then down the track, if necessary, they'll have the other testing. So be mindful of that. There's really good advice there from ATAGI that Nick's alluded to. And one of the wonderful things from ATAGI is this, you would have all seen it, but this is really useful to have printed out and talk to people who are less than 60 about the blood clots, because it presents really nicely graphically. Nick showed it in a table earlier, that the risk of blood clots on the left, and this is with a medium sort of outbreak scenario on the right, and the risk of disease as you get older is much higher. So if you've got someone who's over 60, it's a really good graphic to show that they're much better off to have the AstraZeneca, and the risk of blood clots in that age group is less, and the usual risk factors for blood clots really don't apply in terms of talking about blood clots with this vaccine. Thank you, and I think I'll throw it back to John, who's going to manage some questions for us.
Thanks, Patrick. Appreciate that. We have got some questions. We've got quite a few tonight, which is good. So I'm just going to keep going through those and ask the panelists if they wouldn't mind turning their video on, and we'll just do a bit of a panel session. Thank you. Noting, of course, that Michael is still in the dark.
Here's the black space.
That's the dark space on your screen. So just a question from Ben Ewald regarding AZ being recommended for Greater Sydney, but how about Newcastle, where we've got much lower numbers, Patrick? You're on mute, sorry.
Mute.
The advice is in an outbreak setting, Ben, so we don't have the outbreak that Sydney does, but I think you can say that Newcastle's now in an outbreak setting, and I think that advice from ATAGI really applies. So shortening that interval for the second dose AstraZeneca down from 3 months is definitely advised.
So, thank you. Karen Douglas has a question related to a pregnant woman who's had AZ first dose. Can she then have a second dose of Pfizer? And does she need to have the form filled in to access that? Joe?
Oh, I'll take that one. I guess it depends where she's going to access her Pfizer from. So if you have it in your practice, who's that? Sorry, is that Karen Douglas?
Yeah, it's Karen. Yeah.
Who I think does have Pfizer in her practice. Yeah, you can switch. That GPs can, the same sort of criteria that we have is the same criteria that GP practices can use as well. So the ATAGI advice is that you can switch to the Pfizer for the second dose in pregnancy.
Thanks for that. Pat, I might throw to you for this one. Queensland is giving Pfizer to over 60s and not questioning it. And a lot of dies up in Bingra. A lot of patients are opting to cross the border for a Pfizer rather than have the AZ. Do you want to just comment on that?
Yeah, I think the yeah, it is difficult, but I think the safety for AstraZeneca has been misunderstood by the public, and the blood clot risk is very, very low for people over 60. It's not a conventional blood clot risk, so you can really recommend that. In Aboriginal communities, if you're working in AMSs, you've got a high risk population. You can, if you've got someone that absolutely won't have an AstraZeneca, then I think it's reasonable to give them a Pfizer in remote, especially with the disease out Walgett Way now. Yeah, so it's difficult. I think this problem's going to dissipate a little bit as Pfizer becomes more available in a few months' time. But at the moment, the principle of giving younger people Pfizer, because they're the ones who are going to, if you don't want an outbreak in your town, you want to be giving that Pfizer to younger people and giving the AstraZeneca to people over 60 as much as possible. So it's a way of managing a scarce resource, but it's a way of managing a scarce resource in a way that is not putting those people at risk.
Thanks for that. Can someone comment on the incidence of lymphadenopathy following vaccination?
It's not high, but it occurs. And the thing is, it's not, some people complain a lot about pain under their arm, and it comes on as a delayed onset. So people find it troublesome if it comes on a week later, because they don't understand why that should happen. They don't understand immune responses take about a week, 10 days to happen.
Thanks for that. Is the history of a CVA a contraindication for AstraZeneca?
No.
Thank you.
No.
Thank you. Thought that was the answer we were going to get, but I just wanted to clarify. Is there any advice for a patient with a past history of Stevens-Johnson for their first dose?
A past history of Stevens-Johnson, if it's not related to a COVID vaccine, is somewhat irrelevant, because really that's a specific reaction to a specific set of circumstances or drug. It's not a universal event that's going to happen for every single possible trigger for Stevens-Johnson. It's immunologically specific.
Thank you. Yep. Has there been any research on the side effects with people who've been diagnosed with epilepsy?
It's Patrick here. No, I don't know of any specific research, but there's certainly, we're looking really hard, and epilepsy hasn't come up as a pre-existing medical condition that side effects have been increased on. And Michael's pointed out nicely that this is now a common vaccine. We've got a lot of data. We know a lot about it, and epilepsy hasn't come up as an issue. Because you're giving someone a needle and causing pain, you know, it's possibly a precursor to having a fit if someone's not medicated properly. So all your normal epilepsy management would be in place before they'd have the vaccine.
Thank you. Sorry, I just lost my place here. How soon after a vaccine do you see GBS or CLS, and what are the common presenting symptoms? I think you've covered that, but we probably could reinforce it.
The biologically plausible interval for GBS after any vaccine is considered to be 6 weeks. And Michael, did you want to comment on the rest of that question?
No, I think the 6 weeks window is considered correct. There is a rate for Guillain-Barré in the community all the time, which occurs within a 6-week period. And so far, it's been difficult to demonstrate whether the rate of GBS is above that background rate for the vaccines. So although there's great concern about that, I've had a number of questions from people about that, the data currently does not support that there's conclusive evidence that the rate for GBS is higher post-vaccine. Though, of course, this will continue to be watched, and I may be proven wrong in 2 weeks or 3 weeks, but it does tell you that if there is an increase in rate, it is going to be low. It's not going to be like every second injection, or it's not going to be like TTS. It's going to be quite rare.
Thank you, Michael. Anik Carruthers has asked, would someone like to comment on vaccine in breastfeeding?
We would recommend it, and it's currently recommended, as it is for pregnant women. And it's a problem that people need to move and do it.
I think there's probably a bit of, maybe Annette's alluding to, there's a bit of confusion around the messaging around the Pfizer vaccine and AstraZeneca in that age bracket. So when ATAGI made the shift to recommending Pfizer for under 60-year-olds, and then captured that for pregnant women as well, then the assumption was that that was also the same for breastfeeding, I think, for many people, but it's actually fine to do AstraZeneca whilst breastfeeding as well, if that's what the woman would like to do.
Thanks, Joe. Patrick, I might ask you to answer the question around why only 6 doses by protocol when there are 7 available in a Pfizer vial, and also there are 11 available in a AZ vial, but only 10. One's being wasted.
Why the companies or the recommendation is like that? They didn't consult me at the time, unusually. I think it's just to make it practical. Just to make it practical.
When we were doing large volume draw up, the other thing was people often mucked it up a little bit, and when you actually tried to pull that last dose, they found they were short on the vaccine, and so the companies argued they needed a little bit of overfilling, but they didn't necessarily have the full dose for the 7th or the 11th. Yeah. So when we're doing it in the hub and you have someone just doing it with the meticulous non-redraw special syringe, you can do it. But for an average person in an average clinic, it's thought that you won't get the 7th or the 11th dose accurately full.
Thank you for, that's a good point. Patrick, again, the Pfizer vaccine arrives in a sponge cell inside a cardboard box. Should they remove them from the box and place them in the fridge, or leave them in the box and place them in the fridge? It's a really good fundamental question.
Yeah, it is. So no, they as much as possible, we try to store vaccines in their original packaging. Yeah. And again, because it's fragile, so you do that. You leave it in its original packaging as much as you're able to until you're ready to use it.
Thanks for that. With the limited vaccine world supply, can you give us some information on the COVID vaccines being used in other countries, such as Sinovac or Sinovax? Anyone want to take that?
Yeah, it's a great question. So yeah, there's everyone's after vaccine. So some countries are manufacturing a lot of it, especially the Europeans and the Chinese. So we've started to manufacture the AstraZeneca here in Melbourne, and we're sending some of that to the Pacific. The Chinese have got huge output, and they're sending some of their vaccines, which is Sinovac, to many countries. There's some media reports from Indonesia that there's about 500 doctors and several hundred nurses who've had 2 doses of the Sinovac who've ended up dying of COVID. So it depends on your source of information, but those media reports would suggest that maybe it's not giving the amount of protection that we would like.
Thanks for that. Question, I think, for Nick. If a patient suddenly dies within 5 weeks of an AZ vaccine, should this be reported by the GP to ATAGI through, even though, sorry, the coroner did not ask for an autopsy?
Yeah, so I think we need to be reporting those to the public health unit if there's no clear other cause of death. So if someone's died of something else that you know what they've died of and you sign the death certificate, then they don't need to be reported as an adverse event after a vaccine. If someone has an unexpected death, then we really should be reporting them and having a look at those. Did you want to add to that, Joe or Michael?
No, I think that's reasonable, Pat. We would report it if they died in hospital, for instance, whether or not. But would that would occur, but we would not mark it down as due to vaccine if we knew it wasn't.
Yeah.
So someone can have a look at it, but don't say things are vaccine when they're not.
Yeah. Thank you. We've had a couple of questions that relate to the efficacy when the second dose is brought forward to 4 to 6 weeks. And the questions really relate to how much of a drop-off occurs bringing it forward. Is there an algorithm essentially that says at 12 weeks you've got this, at 11, 10, 9, 8? Is anyone want to comment on that?
Okay, I can comment on this one. So when they rolled out AstraZeneca originally, in the original efficacy data, they rolled it out at 4 weeks. Our friend, Mr. Johnson, decided that he would delay it. So Boris got out there and said, we're going to delay it for 3 months to get more vaccine in their arm. So that's what he did. There was no rhyme or reason to do that. There was no plan. That's why AstraZeneca has trouble with data, because people have made political decisions to do things around the AstraZeneca rollout. So the data is well collected. The population data was very good. But when you say, would it be better at 6 weeks, 8 weeks, all those things, there is data for AstraZeneca on any time point you want to mention. And all of them are to do with, this is what we did in this group. And the data is all comparable, which is why they can say 4 weeks, 6 weeks, 8 weeks, it all works. Pfizer didn't do any of that. They just said, we're going to run this very dramatically. We're going to do it at time this and 3 weeks later. So when we extend it out to 6 weeks and 8 weeks, there's limited data that you can do that, but the limited data that exists says it works fine and there's no major difference. When you roll out a vaccine, you try and make specific time points so you get clear answers, but they're all based around the time points. That's why the data outside of the time points is more limited, but it all says it works.
Thank you for that. In places like Moree, Patrick, I might ask you to comment on this one. In places like Moree with a large Indigenous population, would giving Pfizer to 12 to 15s should we be giving Pfizer to 12 to 15-year-olds?
Yeah, it's a great question. Not at the moment. So the recommendation for 12 to 15-year-olds is medically unwell. all Aboriginal people over 18. The current epidemiology says that it's young adults that are bringing the virus around, traveling from place to place and transmitting the virus. So the focus really should be on young adults from, say, 18 to 40. They often are not people that have a lot to do with the medical clinics. So they're not going to be lining up at your door for the vaccine. You really need to be searching them out, getting your practice software, sending them messages, getting them to come in for the vaccine. There will be some sort of school program at some stage, depending on the supply of vaccine and the epidemiology, and that's when the 12 to 15-year-olds without medical conditions will be vaccinated. But at the moment, the best way to prevent the spread of the virus is vaccinating young adults.
Thank you. Leslie Dunnicliffe has a question which relates to the digital certificate. She has a patient who had a AZ first dose and a second dose of Pfizer. He can't get a digital certificate. Does anyone have any advice on that? My recollection is that in the MyGov app that both doses of vaccine are listed as being given, but the certificate is not generated because the cycle for one or other has not been completed.
Yeah, John, you're right. That's my understanding as well.
Is there likely to be a way around that for people who've had one and then the other? Or any
I'm
thoughts?
assuming there'll be a fix in the future, but at the moment, it is the way that you've described it. Yep.
Yep. Question in relation to the time interval to watch for leaky capillary syndrome. Michael?
I'm not sure of the answer to that precisely, because it's not one I have been asked. I've looked it up.
Can we take that on notice? And
we can answer that when I've looked it up.
I think we'd be interested in anyone that looked like they had capillary leak syndrome, regardless of time interval.
Regardless of the timing. We'd be fascinated and go for it, yes.
What's the advice that should be given to people presenting for COVID vaccination who have a mast cell disorder?
Okay, that I should answer. So it depends on what is the nature of their mast cell disorder. So that all goes from, if you have a mast cell disorder where you don't have anaphylaxis, you've never had much at all, then, and it's largely a skin or dermal one only, then you would just give some gentle antihistamines and you wouldn't be too concerned. At the other extreme, you have people, I look after 2 or 3 of them, who have anaphylaxis a couple of times a year, despite very aggressive treatment. Those you would want to do somewhere with observation and planning. And all in between, there are people who are very well controlled on antihistamines who would be reasonably safe to vaccinate, and there are those who are less so. So it depends on the individual. Most of those people have an immunologist or someone who looks after them regularly, and you would ask that person to give advice.
Thank you. We're nearly at the end of our time, but I've got probably one question that I'd like to get the panel's view on, and it's one I've been asked quite a few times. And Wayne Halpin's asked this question. The most common reason for vaccine hesitancy in his experience is the patient saying that the vaccines have not been used long enough for us to know the long-term safety profile. Who wants to answer the elephant in the room?
How long do you want? We've been going for a year and we've given 2 billion doses. And most vaccine side effects that we see that are relevant occur early. Tell me a long-term vaccine side effect from the vaccine that is currently released and that we used. Anyone? Is there any? Almost all of them become apparent within 6 to 12 weeks. At the maximum would be 12 weeks. Yet we're worrying about it when we've known this is rolling out for more than 12 months. I think it's a red herring, to be honest. We haven't had this as a problem with any vaccine.
Yeah, and I think to some extent the media have played a large part in in this, particularly in the early days. And I think that the science and the advice that's now making its way to the media is to some extent countering that. Can I
Patrick,
just
g'day to Wayne, and that's why I put up the ingredients in the vaccine. There's nothing in there that's sinister that's going to cause a long-term problem. Tough.
So there's no Microsoft chip in the vaccine that's going to track me for the usual social media rubbish that
I can't get the Microsoft chip in my computer to work. I can never learn one in the vaccine.
True. Look, it's 7:59. I'm going to wrap up now, but what I would like to say is a couple of things. Firstly, those questions we have not answered, we will attempt to answer over the next couple of days and circulate with the slide deck. The slide deck will be available, as will the recording of this evening. Can I encourage you to get your colleagues to watch this presentation, and please share the information that you've had with your colleagues through your normal channels or social media or whatever's appropriate for you. And I'd just like to thank all of our panelists for giving up their very valuable time and sharing their expertise with us tonight. Thank you.
Thanks, John. Thanks so much for joining us tonight and sending in your questions. I'd also just like to take the opportunity to thank all the panelists. It's been great working with you, and yeah, thank you for taking the time out to also prepare your presentations for us. As John mentioned, the session is being recorded and the slides will become available. So to access these, it's just in our education library on our website. There will be a short evaluation survey that will pop up when the webinar ends. If you could just take a moment to fill that out before you log off, we really appreciate any feedback you can give us. So thanks again, everyone, for your time tonight, and we hope you have a safe and enjoyable evening. Good night.